So, welcome everybody who's watching this new Sunstar Conversations episode. For those new to the series, every 2 weeks we have an open discussion with a renowned expert about a broad variety of topics. And today we will be talking about quality of life and oral health. And we will be doing this with our guest, Professor Georgios Tsakos, who is Professor of Dental Public Health at the University College London and Chair of the Platform for Better Oral Health in Europe. So welcome, George. How are you?
I'm very well. Thank you very much for having me. I hope you're well as well.
It's an honor. Yes, thanks. So first, as a general comment, if you are watching and you have any question during this conversation, you can ask them in the chat. Or if you're watching on Facebook, you can just post a comment below and then we will address them during the conversation. So as a start, I think it's important that viewers know what we mean by the concept of quality of life. I remember from when I was doing research myself into quality of life that I found it sometimes difficult to explain the concept in easy terms. So I was eager to hear from someone who is rightly considered to be an expert to give it a try, to explain this in an easy way.
Yeah, usually the first question is the one that breaks the ice, isn't it? I don't think that one is like this because actually it's a tricky one. And I think the more you go into it, and actually, Martin, yourself, you have produced papers on the topic, so you're very familiar with that we turn to use terms which are big in oral health research and health research, and they don't mean necessarily something very specific, or to be more precise, they can mean different things to different people. Yeah. So in a way, this is what happened with the quality of life term, which has also been used in different connotations. It has been used as oral health related quality of life, sociodental indicators. These are terms that have been used almost interchangeably, putting one or against the other, but they mean, how can I put it simply? I think they mean the importance of the perceptions of people, of subjective perceptions in how they assess oral health and how their oral health affects them to carry out basic activities of daily life. So how oral conditions, if you like, limit them and to what degree in terms of basic things we do on a daily life, like eat comfortably, speak, socialize, have your mood being affected and feeling a bit more upset, even your social life, your psychological life, physical roles, all that.
Yeah, so if I understand correctly, it's a concept that goes beyond the actual problem that you have in your mouth, but more that it has an influence on everything that you do in daily life.
Yeah, it goes beyond. It actually, some people, and I want to make some small parentheses, some people think that the minute those measures came up, those subjective measures, when I say subjective, I mean patient reported or measures came up, they thought, okay, we have found a substitute for the clinical measures. We don't need clinical measures anymore. That's wrong. They convey very different information. The clinical measures are there to present useful information about the disease process and how the oral diseases are performing, if you like, while quality of life measures is how people themselves perceive the impact of the oral conditions, of the oral diseases on their daily life. As I said, for example, consider that you have dental caries. That's the most prevalent oral disease. Yeah. From a quality of life point of view is, has the disease affected your ability to eat properly? Has this disease made you have difficulty in relaxing and sleeping because of toothache it might have caused or anything else? So it's how it translates to the daily life of people.
Yeah. Yeah, you mentioned the caries there. Are there any examples of well-researched oral diseases or conditions that strongly affect quality of life?
There is, it's a good question because there's a lot of evidence about this topic. And actually when those measures first arrived in the field, they arrived sort of in the 90s and onwards, for children a bit later. So they are around for quite a bit of time. Initially, as I said, they were viewed with a bit of skepticism and what are there to do. And going on, researchers in epidemiology, which is the distribution of disease in groups, in populations rather than people, have started using them more and more. And also our clinical colleagues have started using them, but for a different reason. So there are, to answer your question, there are two streams of research to answer the point. One is on studies about, does the disease in the population has any impact on the daily life of the population? And another is, if we treat the disease, does this improve the quality of life of the population? So there are two different streams of research, both very useful.
Yeah.
First one, we have an awful lot of information actually, and even systematic reviews, which are in a way studies that synthesize, that put together the evidence from many other different studies to show that oral conditions, can give you the example of tooth loss. There's a systematic review on tooth loss, and it affects considerably the quality of life of people. So losing a number of teeth impairs their ability to undertake daily life activities, important ones. And there's also one in, not one, more than one in terms of periodontitis, which I'm sure you're very familiar with the literature because your research has been around the periodiabetes field. There's reviews, systematic reviews that put a lot of studies together to show that gum health, or the reverse of it, inflammation of the gums and periodontitis, are linked with worse quality of life on people that have it compared to healthy people. So there's a lot of that now.
And there's also evidence that when you're treating these problems to the gums, that this also leads to improvement in quality of life.
Indeed, and that's the second stream. That's why I tried to separate the two, because I think it's interesting to understand how we can use those measures. What do we mean by quality of life, and where those measures apply everywhere? That's a different application, which tells, in essence, we're asking the question, can we put those as a measure of outcome of the treatment? You know, if we treat the disease, does it result in better quality of life on people? And there are studies, and quite a few studies in periodontal disease, as you mentioned, other conditions as well. But in periodontal disease, we also have systematic reviews. So big studies that take a lot of studies together, and they show that treatment of periodontal conditions lead to improvement in quality of life. Now, how much is a different question, really, and a very important question. How much of a difference it makes.
I was going to save this statement actually to a later stage, but maybe we can already tackle this. So if you, on the one hand, see the treatment outcome in clinical parameters, so improvement in measurable oral health or quality of life, which one would you consider to be more valuable for a patient? So from a patient perspective.
It's an interesting point, because I'm a dentist that does social epidemiology. That's an epidemiologist and public health dentist. So in essence, I try to see both sides of the spectrum, and I view them as two sides of the same coin, if you like. So I view them as very complementary aspects of oral health. So I would be very, very, very suspicious if someone says, I don't care what happens in the clinical measures, I just want to see people feeling better. Yes, I do want to see people feeling better. At the same time, I know how important it is that this is not just a perception, but also is based on sound evidence about treating the diseases. So I would suggest that this is a distinction that, to me, is a fake one. I don't want to use the term fake with all the misuse it has been done in the last few years, but I think one needs to put things into the context. So clinical measures are important in their own right. Quality of life measures are important in their own right. They both complement each other. So if you want to see an outcome, you actually have to take both into consideration.
Yeah, good point. Yeah. We see a question coming from Facebook, and it says, what is included in quality of life linked with oral smile halitosis?
Well, it's a range of items. And again, as you would expect in an expanding field of research, it is true that this field, starting from nowhere 30 years back, has become almost the flavor of the month. You know, you go in a big dental research conferences, there are session after session dedicated on oral health related quality of life. I would say that it's different aspects of daily life. So halitosis is a symptom that can affect, for example, how people feel about the mouth and how confident they feel about socializing. And that is very important. Eating difficulties is the most prevalent, the most common, let's put it like this, impact of the oral conditions that we see across the studies. But I like the point made about the smiling.
Yeah, the aesthetic aspect.
Yeah, it's the aesthetic aspect. And I want to give you an example. A few years back, we've done in a big consortium of academics and health survey organizations, the national study in the UK on children's mental health. And we measured a number of clinical indicators in different ways, and also had an extensive children and parents questionnaire to get information. So we've collated all that in reports and scientific publications, and we thought that we have a message that says, oh, oral health seems to be improving in general. However, there are some considerable issues. It's interesting that what was picked up by the press, what the society in general understood, it was the impact on smiling more than anything else. What made the headlines, it was that almost a third of 12-year-old children or 15-year-old children say they're embarrassed to smile because of how their teeth look. So the comment that was put made absolute sense. It is about smiling, it is about socializing, it is about enjoying the contact with other people, it is about function. Primarily, it is about eating, speaking, the aspects of daily life that oral health can impact upon.
Yeah. I remember when I was using one of the measurements for oral health related quality of life, that it can also be a bit ambiguous. And I will give you an example. For example, if somebody has needs a tooth to be extracted, a molar or a wisdom tooth or a normal tooth, it can have two effects. On the one hand, it will alleviate pain, so it will reduce the pain because the inflammation or the tooth hurts, and when you extract it, the pain removes. So that's an improvement in quality of life. But at the same time, it can also impair your functioning of your oral cavity. So it makes eating difficult, can impair your speak. So you can have, at the same time, having a treatment can result in improvement or in declining quality of life. And I think this is a thing that makes the use of quality of life as an outcome also a bit difficult. What are your thoughts on that?
Yeah, I agree fully, and I mean that's a good example. But you can also think of we think of conditions sometimes alone, but you have to think that those conditions, those oral conditions, that don't happen in a vacuum. They can coexist in people's mouths. So while one might take you from one direction, the other in another one, well, yes, it's a complex world. It makes it even more interesting to research on it and understand what goes underneath. And I think in a way, you answered in a very good way the first or second question you posed on me, which was, what should I use as an outcome? You see, in a case like that, you have to put context into consideration. And I think a lot of the times we tend to say, oh, let's find what is what we call as scientists a statistically significant difference, hang on to it. We found a bit of a difference, we justify a procedure. It's not like that. It is a bit more complex than this, and one has to look at the whole spectrum. Particularly in an area on value-based healthcare, where you need to justify what is the value of your health interventions, and oral health is part of health. Yeah.
I see we have another question that sort of follows up on your previous comment on the research with kids. And it asks, do you see loads of problems for kids and quality of life? Has this been measured? Is it a big problem in children and adolescents?
Yes, has it been measured? Let's answer the easy one. Yes, it's the answer. It has been measured in the different settings. I just gave the UK as an example, but there are many other studies across the world that have used measures of oral health related quality of life or quality of life measures in surveys of children. Do the children report high prevalence of impact of oral conditions? Yes, and initially it's interesting that if you look at historically how these measures started, we initially had focused more on older adults and adults, and children were almost excluded from the measurement, if you like, because there were reasons for that. It's quite difficult. Some of these concepts, as you correctly said, Martin, they are quite difficult to define, and you know, psychological well-being, how do you ask that on a very young child? It's not so easy. As the field grew, we realized that following developments also in the broader health field, that it's possible to measure. So there are measures that are simplified in the wording and they applied for younger children. If you go in very young children, then a lot of the times you have to also have what we call the parental report. So you ask the parents, it's usually the mom, about that. So there are a lot of methodological issues. I don't want to go into that, but yes, it has been measured. Yes, to report oral impacts, quite considerable ones, and this has a value. And I think the value comes more if you put it on a broader context. Think, for example, of how we try to communicate the importance of oral health to policymakers.
Yes. Yeah.
It is the message cuts easier through when you talk about the impact of oral conditions, of oral diseases on people's life, rather than when you put a mean score of DMF, which is the measure we use a lot of the times to refer to Carey's experience. We understand what we mean by that. It's a very clear thing, but it is difficult to resonate with a politician that has to take decisions about healthcare in general. While if instead of going for that alone, you say, but that also causes so many school days lost, or those problems in children's quality of life, then suddenly the message becomes easier translatable to a lay language.
It becomes tangible.
Yeah.
So I agree. I think it's a very important outcome for health policymakers to sort of also understand sort of the rationale behind the science and behind the outcome. And
I've had first-hand experience for that. I mean, being involved with the Platform for Better Oral Health in Europe has helped me in many respects on that, to understand, to see that actually happens. It's when you start talking about the impact of the oral conditions on daily life, when you start talking about the inequalities in the society, big things like that, that, you know, resonate with the broader sort of message and puts oral health well into the agenda.
Yeah. You've mentioned a few times that research into this topic has started 20, 30 years ago. I assume you have also been involved in this research, maybe also in the early days. Can you maybe sort of explain at that time of your professional career what drove you to dive into this, at that time probably a very conceptual new topic that maybe not everybody was too happy to dive into?
Yeah, I don't consider myself one of the pioneers. There's a generation that started it, but actually I was very lucky to do my PhD with an eminent scholar in data public health. For me, one major figure in data public health, Aubrey Hayem, who actually introduced me to this very innovative thinking early on. And what sort of triggered me to you know, then as a very early PhD student to go into that field, it was the idea that suddenly there was something that could make sense and I could compare across populations. So I wanted to understand what does, I was doing it on older people, I have an interest in aging and oral health, what does it mean to the people themselves? I could understand what it means to me as a dentist, but it was more understanding the so what for the recipient of the care. That was the major thing that sort of said, well, it's worth spending time on it.
And in more recent years, are there any interesting findings or maybe some findings that have had a direct impact in daily practice or in healthcare policy that you can give an example for?
That's a difficult question. Impact in healthcare policy in a period of COVID, God knows. I mean, it's a difficult question, isn't it? I think
maybe not so recent. Maybe also in the past.
Yeah, I think if you look in the last few years, I think that there's an interest. It's sort of, there is a need for the field to mature. Imagine a good wine that stays in a barrel, in a bottle for too long, and you have to get the right age for it to be perfect. So I think we've reached the stage in that field of quality of life where we had a lot of studies developing measures, testing them, validating them, which is very important, but it's not the final outcome. So we are getting now into studies that are looking more about the concepts behind it. And I think we need a lot of work on that. We're getting into understanding the pathways of the outcomes, how we go from the condition to the impact, understanding a bit of more mixed methods and qualitative research. And we're getting also into analyzing what happens in trends across populations and trying to see which are the factors that make a difference. To give you an example, looking at change in quality of life over 10 years in national surveys in the UK, we could understand where the improvement was. So there was an overall improvement that coincided with the improvement in oral health in general, but there was still a sizable minority that had really an impact in the daily life because of their oral health. So that sort of makes you understand that looking at trends, that we have an issue of inequalities here. It's very well documented, and this is a group one cannot neglect. And we could sort of research and see that this is not just a passage of time or a specific age cohort. It's like a combination of issues in terms of clinical status and also aging process. Different age groups will have different, will be differently in that association. And that I think the more analytical epidemiology is what I find more relevant in recent years, because it helps us understand the more tricky questions behind it.
Yeah, that's really interesting that you say this, because this is also something that I wanted to ask you is, are there things beyond the oral health that can influence oral health related quality of life? You mentioned age groups, for example, but maybe also socioeconomic status, ethnicity, these typical research categorizations, are they also of influence of quality of life?
Yeah, I mean, you hit the nail on the head there. The big issue we are facing in health is around health inequalities and the broader social determinants of health. Quality of life, or health-related quality of life, is just one of the outcome measures that actually shows a similar pattern of social gradients, that the disease is socially patterned, and the impact of the disease is socially patterned. It is predominantly impacting on the lower socioeconomic groups, the more disadvantaged section of the society, and that is really a major call to action in terms of addressing inequalities in health, and oral health is an integral part of health.
Yeah. Just a quick reminder for those who have just tuned in, if you have any questions on this topic, quality of life and oral health, you can ask them in Facebook if you're watching over there, or in the chat or the Q&A in this webinar. And there's one in the Q&A who's asking, taking physiological aspects into account, psychological, sorry, have you seen a difference in the oral health of patients and the change of habits in their quality of life during and after the COVID situation?
Well, that's a very temporal question, isn't it? And COVID has had, we have, at the moment, we have what we call narrative review. So we have little hard evidence about oral health, but everything points into a direction where, for a start, care has been stopped in many parts of Europe and the world, and it still only gradually goes back. It goes back with an increased cost for the dentist, but also for the dental professionals, but also for the recipients of care, where in most cases care is provided privately, so for people. At the same time, during the lockdown, and it's interesting, if I can pick one point from that question, it talks about psychological aspects. There has been a major psychological aspect. There has been also a major behavioral aspect. I mean, snacking has increased, high consumption of high sugar foods has increased. Oral hygiene, I mean, it's only a logical consequence that may have suffered a bit during that period that we all facing a prolonged periods of lockdown in different parts of the world. This only, we need studies to sort of calculate the exact effect that will have on population's quality of life. But to tap on your question about inequalities before, the obvious impact it would have, it would not reduce inequalities. If anything, it would exacerbate them. It would make them larger.
Yeah.
So there's a big challenge ahead, and I like the fact that it was related to that challenge we're facing. That's an added complication that we need to take into consideration in a post-lockdown situation where we go back to some sort of new normality.
Yeah, yeah. Interesting. So I have another question, because we all know, well, most of us know that oral health doesn't stand on its own. It's also related to general health. Conditions in the oral cavity or in the mouth can also influence your general or systemic health. Is this also the case for quality of life? Do we see this sort of connection as well? Do you have any experience in that topic?
I do, but I think you also have as well, because you have done work on diabetes and periodontal disease, which is one of the key areas, not the only, but it's one of the key areas where we see the links with oral and general health. And those links, I'm actually, it's good to see that they have become more apparent in the last decade, because they were usually in the beginning only about periodontitis and a number of other general inflammations. Periodontitis is a typical example of an inflammation of the mouth. And there's strong evidence about links epidemiologically, but also studies, as I said before, studies on treating diseases, so not just on populations. But there's also a lot of studies on aging and health, where the links are obvious, the links with frailty, obvious with function, with a number of comorbidities, but also on younger children, where caries affects development and growth in children. So oral health is just an integral part of health. I mean, there isn't a body without a mouth. So this distinction between oral health and general health is a technical one, it's an arbitrary one, and it has no conceptual basis. So it's about time we have reinstated the mouth back into the body where it belongs. And there's evidence now, even from studies that have used, I mean, a typical example is studies that have used treatment of periodontitis on diabetic patients, and they saw improvement also in quality of life, not just in clinical markers of diabetes. So there are examples of that studies. You're right.
I fully agree. The thing that we saw is when you sort of divide patients into people with poor quality of life related to their mouth and those with good quality of life, what you saw is that those with the poor quality of life in the oral health related also showed general health related quality of life decrease. So I can fully agree that the two concepts are completely integrated, and it also shows in quality of life, which it only underlines how important these relationships are.
Because at the end of the day, both oral and general health, those chronic conditions are socially patterned, and they happen predominantly in certain groups in the society. So they go hand in hand.
Thanks, I agree. So I see that we have another question from Facebook. Do you feel that the criteria of good quality of life has changed through the years? Has the perception of patients changed over the course of time?
Yes, it's a dynamic construct. It's changed over the years. It's different between different societies. It's different between different groups. What is an acceptable oral health, what is an acceptable dentition even, is not, one size fits all. But we tend to agree more or less on that, talking about the functional dentition. So and it's interesting that we talk about how we will maintain a good oral health throughout the life course that will give us the ability to function well in a society. It's not like health as no disease. It's about how we manage a good level of oral health to maintain a good life and make the most of the opportunities in life. So that changes as we grow, it changes by our experiences. It remains important at different ages.
I agree. I think there's time for one more thing, and that is what I wanted to ask you. Is there any future research or any future directions that you are focusing on now, or that you're going to do?
I sort of hinted a bit, and I think it's not just for me. I think the field, what we require more is a bit more analytical input on the quality of life and understanding the underlying pathways that link the clinical conditions and quality of life outcomes, and also thinking a little bit more conceptually how our perception of quality of life, and particularly our measures, fit the current sort of framework, which is very different from the framework of disability that was in action when those measures appeared. So we're talking now in a bit more sort of inclusive way of what it means. I think we need some conceptual work, which doesn't affect, in a way, it's not of interest to the general public, but we also need a bit of analytical work to understand how the pathways between the broader determinants and the outcomes. And quality of life is a major outcome in that respect.
Yeah. I think that's a nice way to close this discussion, because I can see we've already been talking for half an hour. So time flies when you're having fun, I guess. This conversation has been recorded and will also be posted on YouTube. So if you have tuned in later and if you have any questions afterwards, don't hesitate to watch it back on YouTube or contact us if you have any questions on this topic. The next one will be on the 5th of August, where we will be discussing the implications of smoking on oral health. So I hope to see you all on the 5th of August again. And for now, I want to thank George for his wonderful contribution to this series.
Thank you very much.
And good luck with all your future research exhibitions on quality of life. And I want to thank the rest for viewing. So have a great day.